All right, welcome, future specialists. You know those TUS questions about dysphagia that just make your brain freeze? Well, you're in exactly the right place. Today, we're going to tear down esophageal disorders and build a logical framework from the ground up. The goal? To make these questions some of the easiest points you'll get on exam day. Let's jump right in. So, here's the game plan for today. First up, we're going to decode dysphagia. Then, we'll get into a big showdown between the major motility disorders. After that, it's all about GERD and the risks it brings. We'll wrap things up with a classic TUS case drill and then a super fast review of the most high-yield facts. Look, we're not just going to list diseases today. We're building a mental toolkit to absolutely crush any esophageal question the TUS throws at you. Okay, Professor, let's just get right to it. The number one thing that always trips me up, and I know I'm not alone here, is dysphagia. You know, you see a question that says trouble swallowing solids, then liquids, or maybe it says trouble with both at once, and my brain just locks up. Can we please, once and for all, build a foolproof way to think about this? That's a fantastic question, and honestly, it gets right to the core of what we're doing today, thinking with a mechanism-first approach. So let's throw memorization out the window. The answer here is all about pure, simple logic. It's basically physics. Let's break it down. Okay, so think about it like this. Is there something physically blocking the pipe, or is the pipe itself just not working right? It's that simple. If you've got a mechanical block, a tumor, a stricture, the pipe is getting narrower. So what's going to get stuck first? Of course, the big, bulky, solid food. Then, as it gets even tighter, liquids will start having trouble. But what if it's a motility problem? Now the pipe itself is broken. The muscles aren't pushing things along correctly. In that case, who cares if it's a piece of steak or a sip of water? Everything is going to have trouble right from the start. See? The sequence of symptoms literally tells you the story of what's going on inside. Okay, so for a TUS question, my first mental checkpoint is this. Is the patient coughing and choking the second they try to swallow? That points to an oropharyngeal problem, right? Like a transfer issue. Or do they swallow okay, but then get that awful sensation of food being stuck in their chest? That's the real esophageal dysphagia we're digging into today. Is that the right way to split it? Exactly right. You've just nailed the first big split in the decision tree. So with that in mind, let's dive into the big motility disorders that the TUS just loves to ask about. They're the perfect examples of this whole mechanism-first idea. So everything, and I mean everything, comes down to this one key player, the lower esophageal sphincter, or LES. Think of it as a gatekeeper. It has a really simple job. Open up to let food into the stomach, and then slam shut to keep it there. All the problems we're about to talk about happen when this gatekeeper messes up one of those two jobs. Right. So let's run with that idea. Let's apply our mechanism-first thinking. Food's made its way down the pipe. It gets to the gate. What happens if that gate is just stuck shut? It just refuses to open. What pathology does that create? Boom. That right there is the exact pathophysiology of Achalasia. The LES won't relax, its resting pressure is way too high, and to make matters worse, the esophagus itself just stops squeezing. So what happens? You get a massive traffic jam. Food, liquid, everything just backs up. The esophagus starts to stretch out, becoming this big, dilated bag of old food. That's why patients regurgitate stuff they ate hours ago. And this is where it gets really dangerous. That backed up food can easily spill over into the lungs, causing aspiration pneumonia. That's a huge cause of death in these patients. It's a critical point. And you know the T loves to give you those classic imaging findings, right? So when you get a case with a barium swallow and it shows this massively dilated esophagus that then tapers down to a super narrow point, creating this very specific shape. Got it. So that's one of those automatic associations. See bird's beak? My pen is already writing Achalasia, locked and loaded. Perfect. Now let's flip this on its head. Let's say the gate, the LES, is actually working fine. It opens when it should, but the problem is higher up. The body of the esophagus is just going haywire, contracting in this totally chaotic, useless way. What does that picture look like? That scenario is diffuse esophageal spasm, or DES. The best way to think of it is like a lightning storm inside the esophagus. Instead of that nice, smooth, peristaltic wave pushing food down, you get these crazy, powerful, simultaneous contractions all over the place. And here's the key difference. Because the LES usually works okay, the biggest complaint isn't always food getting stuck. It's crushing retrosternal chest pain, the kind that can easily be mistaken for a heart attack. That's a massive clue in a TUS question. And you guessed it, just like Achalasia, DES has its own classic buzzword on a barium swallow. All those chaotic contractions twist the esophagus up, giving it this really distinct contorted look.
Okay, I'm with you. Bird's beak is Achalasia, corkscrew is diffuse esophageal spasm. Got it. These visual cues are pure gold on the exam.
Excellent. So we've covered the LES failing to open. Now let's talk about the absolute most common esophageal problem there is, which is the exact opposite issue, the LES failing to stay closed when it's supposed to. Let's talk about GERD. Okay, listen up, because this is a huge TUS trap. Everybody thinks GERD is just a weak, floppy sphincter that's always open. And while low pressure can play a role, that's not the main problem. The most significant factor is something called transient inappropriate LES relaxations. This means the sphincter just randomly relaxes when it has no business doing so, not during a swallow, just whenever. And that's what lets all that nasty acid and stomach junk splash back up. This is a high-yield distinction.
And this progression right here is exactly why you have to take GERD seriously on the exam. It's not just about a little heartburn. It is a well-defined step-by-step ladder that goes from chronic reflux to Barrett's esophagus, which is intestinal metaplasia, then through dysplasia and lands you right at esophageal adenocarcinoma. You absolutely have to know this pathway.
All right, enough theory. Let's put this all together and run through a classic TOS-style case. I want you to think through this with me, step by step. Ready? Let's do this.
Okay, let's dissect this. First clue, dysphagia to both solids and liquids. Right away, my brain is screaming motility disorder, not a blockage. Second clue, regurgitating undigested food, plus that history of pneumonia. That's classic stasis and aspiration. The food is just sitting there. And the final nail in the coffin, the barium swallow. Dilated esophagus with a tapered narrowing, that's just a fancy way of saying bird's beak. Every single clue is pointing to one diagnosis.
Exactly right. The diagnosis is Achalasia. But here's a key follow-up question they love. What's the definitive test? While the barium swallow points you in the right direction, the gold standard is esophageal manometry. And why is that? Because manometry doesn't just show you a picture, it measures the problem. It directly proves the pathophysiology, the super high LES pressure, the failure to relax, and the lack of peristalsis. It's the functional confirmation. Fantastic. You're thinking exactly like you need to for the exam. Okay, let's shift gears. It's time for the rapid fire round. This is where we nail down the nitty-gritty details that help you pick the right answer when two choices look really similar. This is how you avoid the traps.
This table right here, this is your secret weapon for any motility question. Just focus on those first two columns, LES pressure and peristalsis. That's the whole game. Look at achalasia, pressure is up, peristalsis is gone. Now compare that to scleroderma. Here the pressure is down, but peristalsis is also gone. That's a classic 2S differential. Then you've got DES and nutcracker esophagus. In both of those, the LES is pretty much normal, but the contractions are what's messed up. They're chaotic in spasm and just ridiculously high pressure in nutcracker. Seriously master this table, and you will own these questions.
Okay, let's finish with one last thought to really tie this all together. It's a next-level connection. We just saw that scleroderma gives you an aperistaltic esophagus, basically a stiff pipe that can't clear itself. Now, imagine that patient also develops GERD. What happens? You've just created the perfect storm. Acid comes up from the stomach, and it has nowhere to go. There's no peristalsis to wash it back down. It just sits there, burning the lining of the esophagus 24/7. The risk for terrible esophagitis and Barrett's goes through the roof. It's this kind of thinking, connecting how one disease makes another one worse, that will take your score from good to truly great. Keep making those connections. You've got this. Study smart.